Hello, and thank you so much for joining us today for the webinar Soft Tissues are Back to the Roots. It is a great pleasure to introduce to you Dr. Dávid Botond Hangyási, whose aim during this presentation will be to present a short overview of different procedures introduced for root coverage and gingival augmentation in the last decades. Dr. Hangyási is a lecturer at the Department of Periodontology, University of Szeged. He practices and lectures for pre- and postgraduate students. His fields of interest include non-surgical periodontal therapy, periodontal plastic surgery, periodontal regeneration, bone and soft tissue management, and implantology. We would like to thank Dr. Hangyási for being with us today and botiss for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Hangyási at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Dávid Botond Hangyási.
Hello, good afternoon to everybody. I'm Dávid. First of all, I would like to say thank you to the whole botiss team for this excellent occasion to be here at Botiss Academy, and thank you to all of you to be here with us today. I hope my sound is clear, and there's going to be some music, and the talk and the music together will be sound nice. I hope so. So, my topic, gingival recession and its therapy, is very popular nowadays. My main title, Soft Tissues Are Back to the Roots, contains 3 separate lectures. This presentation today is the first one of them, called Let's Get Back to the Roots. So we want to get back to the roots, run back over some important issues from the last decades. Today I will review etiological findings and theoretical changes in the therapeutical modalities. I will try to do it in a practical way, enhancing the most popular views and methods for you. Periodontal plastic surgery is very trendy nowadays, leastwise among the dentists, but even the patients hear or read more and more about the new therapeutical methods. There is an increasing need to solve the periodontal problems. More and more people recognize these disorders and needs, and they are looking for answers. They come to your office and ask you to help them. Hey doc, it's terrible, please help me. I can't even smile, it's so ugly. I can't drink anything cold because it hurts. What if it gets worse? Will I lose my teeth? I guess all of these questions are familiar to you, all of you. They want to get acquainted with the treatment possibilities, so they want you to answer the question, do you know how to treat gingival recession? And of course you know how to treat gingival recession. But as they ask you this question, they think about something magical.
It's a kind of magic. It's a kind of magic.
They expect you just to do something magical, just to put something on it, change it in a few seconds, solve their problems right now. But in the meantime, you have only one thing on your mind. And this thing is your blade. But you know, you can't say surgery, because the patient will run away in that very moment. So, if you don't want to scare your patient, you say only one word, plastic. Say it loudly, plastic. People love the word plastic. And then, just mutter under your breath, surgery. Patients don't want to hear it, they don't like surgery. But if you say plastic, they think about something special. Something they can tell to their friends, they can tell it to their neighbors. They get excited to have plastic surgery, they want to have it already, So you both want to have the surgery already. Already Norberg was using transpositional flaps in order to achieve better periodontal function in 1926. All the procedures which aim to re-establish the periodontal function are involved in a big category called mucogingival therapy and can be divided into subcategories. Today we will talk about gingival volume augmentation and root coverage procedures at teeth. The individual gingival makings have outstanding influence on the periodontal function, meaning the attachment of the periodontal support and the nutrition of the fastness against the harmful effects. Sometimes it can be essential to be able to change the gingival biotype to prevent or re-establish the periodontal health. One of the most common goals in mucogingival therapy is the coverage of the denuded root surfaces, thus replacing the lost gingival volume and attachment. So gingival recession is a loss of attachment and displacement and loss of the gingiva. The so-called gingival cleft is a milestone in the development of gingival recession. If you recognize it in time, before losing the periodontal attachment, the disease may be still reversible. It's very important to analyze the causal factors in the diagnostical phase. Traumatic habitual initial lesions can heal spontaneously following the elimination of the causal factors. For example, false toothbrushing technique or flossing. The right gingival cleft shows the progression. This is the front of the disease, a small area of the lesion without attachment loss, so in this area the process is still reversible. If you find a cleft lesion, you can probe it gently just to see if there is still connective tissue beneath it. Thus, if it's red or white. This is a patient with rated periodontitis. Once he came back to the recall having this white cleft. I was really curious if there were any visible signs before, so I checked the pictures from the last occasion and found the red cleft I haven't recognized that last time. As there had been already a recession before, I wasn't thinking on it that there could be a new progression, so it ended up with a deeper lesion. In the next picture, you can see different lesions in different phases. Here is a red progressive lesion, gingival recession, and cervical enamel loss. Now, it's high time to confuse the screenplay of the lecture. Yet we were talking about the etiology, we even mentioned the therapy of the reversible cleft lesions. So we have to jump now to the therapy of the white cleft lesion. In this particular case, the patient had multiple incomplete white lesions. We had to carry out a gingivectomy with a sharp incision and a modified coronary advanced envelope flap. As I promised, we confuse the screenplay a little bit now. Later, when we talk about the envelope flaps, please remember this type of surgery too. And now, let's get back to the etiology and the mechanical lesions. Lip piercing for gingival recession means that the patient is wearing the piercing just to create a nice recession. Let me say that because he didn't want to stop wearing it. Bowel position, orthodontic tooth movements and bad restoration can cause recession too. But even a narrow band of gingiva is capable of withstanding the stress caused by orthodontic forces, for example. Inflammation is a common reason for soft tissue loss. Local inflammation caused by plaque bacteria or marginal inflammation. Non-surgical therapy cooperation between the specialties and patient education are essential fundamentals of the initial therapy. In generalized destructive periodontal disease, sometimes one more surgical phase is needed before recession surgery. Now, we are often on this point again, just to have a look at this case, where periodontal regeneration was needed to eliminate the intrabony defect and to improve the interproximal bony support. After cleaning the lesion, cleaning the intrabony defect, we placed regenerative materials into the socket. Later, if you have a good quality interproximal bony support, you can try to cover the recession. In this picture, you see the intrabony defect and the healing after 4 years on the X-ray. From a theoretical point of view, we can observe significant changes in the last years. As I mentioned before, already Norberg was writing about transpositional periodontal flaps. In 1926, in order to achieve better functional outcome. Function was the first reason to perform this kind of surgical approaches. The periodontium is a functional system, responsible for the attachment and the support of the teeth. If there is a defect, a loss of one or more components, for example gingival recession or resorption of the root or the alveolar bone, the periodontium can't fulfill its role. In the 1960s, Bjorn, Sullivan and Atkins were already using free epithelialized soft tissue grafts taken from the palate for transplantation to improve the clinical outcome. That time, the primary goal of this procedure was not to recover, but to increase the gingival height and prevent progression of the recession. So the free gingival graft is a good choice for increasing the amount of the attached gingiva. It's good for partial root coverage, and sometimes you will need cervical restorations. The free epithelialized gingival graft can be the right choice from the quantitative point of view, but not from an aesthetical, because of its color, contour, texture, and the level of the gingival margin or the mucogingival junction. This is not natural. With the free gingival graft, the broadening of the attached gingiva and the partial or complete root coverage can be realistic goals. Wenström summarized the available studies in 1996. He found that the mean percent root coverage obtained with the free soft tissue graft procedure varied between 11 to 87%, with the greatest success in narrow and shallow recession defects. The calculated average percentage of root coverage was 72%, and the calculated average of predictability of complete root coverage was 57%. The procedure consistently resulted in minimal probing depths. The mean gain in clinical attachment level ranged from 1.6 to 5.3 mm. Later, a two-stage procedure was introduced by which the graft was initially placed apical to the recession, and following a healing period it was advanced coronally in a second surgery. Wenström found that root coverage ranged from 36% to 74%, and the calculated average percentage of root coverage was nearly 63%, with minimal residual probing depth and improved clinical attachment level. At the examination, we noticed elongation and labial position of tooth 3-1 and a minimal band of keratinized gingiva. In this particular case, we were planning a modified Edlam-Meisher vestibuloplasty for widening the keratinized gingiva. In the second stage, we decided to choose a bilaminar technique, a combination of connective tissue graft and a coronally advanced envelope flap with rotational surgical papillas. Now I would choose a coronally advanced flap with vertical incisions or a laterally sliding rotational flap for a case like that. Because of the scar tissue and the muscles, we had a significant shrinkage during the healing period. So in the long term, we could observe a significant increase in the height of the attached gingiva, but not a complete coverage. This so-called bilaminar technique was described originally by Ratzke in the 80s, but the combination of the grafts and flaps was already used by Summer in 1969. At the evaluation of the clinical outcome, we not only consider the percentage of the coverage but the gain of keratinized tissue and the attachment level. And of course, the same principles as the pink aesthetic score. So, in the 60s, 70s and 80s, the main goal was the function, and so the attachment level and the percentage of the coverage. Everybody wanted to use as big grafts as possible. We could obtain that the graft was the issue, it was in the focus. Overgrafting was a usual outcome to secure the long-term results. We have to admit that this kind of procedures result mostly in reparation with long junctional epithelium. The uncovered surfaces were mostly covered by restoration if needed. Then with time and the appearance of the connective tissue grafts and the bilaminar technique, complete root coverage and aesthetic outcome became more and more predictable. If we would like to categorize the types of soft tissue transfer, we could talk about two main groups, and the third one could consist of the combinations of the first two. So the grafts, which are free soft tissue grafts, could be divided into epithelial soft tissue grafts, this is the so-called gingival graft, and subepithelial grafts, this is the connective tissue graft. Langer and Kalanya introduced the subepithelial connective tissue graft already in 1982. Even in the early studies, the connective tissue graft was found to be superior to the epithelialized soft tissue graft. Today, this is the gold standard in gingival augmentation procedures. Nowadays, we talk about the S-more graft as needed. The third group represents a more and more popular theme of the free grafts. The acellular dermal matrix allografts and xenografts, like mucoderm. Mucoderm is one of these 3D soft tissue xenografts. It seems to be an appropriate alternative to the connective tissue graft in several clinical situations, as the clinical outcomes are proved to be predictable in the last few years. The second group, pedicle soft tissue grafts, are advanced or transpositioned flaps with significant blood supply. Depending on the direction of the transfer, pedicle soft tissue grafts can be divided into coronally advanced flaps and laterally rotated flaps. In shallow recession defects, the semilunar coronally repositioned flap can be an option. It is interesting that it was represented originally in 1907 by Harlan. Later, Tarnow modified it in 1986. Summer wrote about the incissionally positioned flap in 1969. Both of them are actually coronally positioned flaps. Harvey, Restrepo, Botond, Allen, Miller, and many others modified the coronally moved flap technique in the 90s and the 80s. So we got to the coronally advanced flap described by Zucchelli and de Sanctis, and the envelope flap from Azzi and Etienne in the 90s. There are still some modifications for these procedures year by year. Zucchelli and de Sanctis modified and published these techniques for different indications. Professor Zucchelli suggests to use the smaller, true connective tissue grafts he has described recently. As he says, the flap is the boss. And we could confirm that the theory changed, the focus moved from the graft to the flap. With these changes, we came up to the point where quantitative aspects meet the qualitative aspects. The golden age of overgrafting is over. Instead of those big grafts, we want to achieve more natural outcome with the small grafts and the flaps. Complete coverage and aesthetics are predictable outcomes according to the described classifications and prognostic theories. And so, today, the treated site looks like the healthy site. The question is it really like the healthy site? Is there real regeneration, or it is mostly still reparation? What kind of attachment do we have now? Is it still long junctional epithelium, or we could hope for connective tissue attachment? The theoretical point of view got more biological, with the aim of regeneration, and so a new need came into being, a need for regenerative materials. In complex cases, comprehensive planning is needed. There is another question I meet in my practice as usual. In my country, most of the gingival recessions are not treated, or all of them are covered by cervical restoration. So the question is, restoration or coverage? I would say it depends on the case. If there is a cervical lesion with enamel loss, of course we have to restore the part of the lesion. In every single case, it is suggested to plan separated to every single tooth. During the examination, you have to set up your prognosis for every site, and so you will know which surfaces you will be able to cover by the flap, and which you should cover by the restoration. The most important rule is to try to work against the disease. Don't wait, don't let it grow. It won't be easier to treat it if it's already severe. Treat it when you can, treat it easily. This patient came to me with this restoration, so I had to change it. The patients and the colleagues as well usually ask me, what if there is going to be a recurrent recession? Does it work to do the surgery? Sometimes we can change all the etiologic factors which are responsible for the lesion, so there is a chance to have a recurrent lesion later. But my answer is always a question. Do you know that there is a chance to have a secondary caries beside your existing fillings? Does it work to restore a tooth even if you know that sometimes you have to change the restoration? Thus, my answer is obviously yes. In this case, and in the following case, I was performing a modified coronary advanced tunnel and pulled a mucoderm inside. This case is now 4 years old. In these 4 years, I had really good experience with mucoderm. This surgery is an envelope flap, a modified coronary advanced tunnel. Sofia Aroka had more articles in this topic. She got good results with in mirror 1 and 2 and even in mirror 3 recessions. In this surgery, we create a tunnel and push a graft inside the tunnel. In this case you saw it was a mucoderm, and we treated the surfaces of the root with endogain. At the cervical lesions we made restorations as well. So we changed the form and changed the gingival biotype. The next case is a localized buccal gingival recession. This patient is a post-ortho treatment patient. She had a really thin gingival biotype. No keratinized gingiva apical to the recession. I had to change the form of the shape of the tooth. During the defect examination, I decided to choose the lateral sliding flap, which is a rotational flap. This is a modification of the laterally sliding flap because it is advanced coronally. After elevating the flap, there is a releasing incision, so we can rotate it laterally. Then we create a bed for the we create a donor bed for the flap. There is always a question, which type should we choose of the soft tissue graft? We can transfer the graft from the palate, which is an autologous tissue, which is the gold standard, but it needs a second surgical site. Or we can take an acellular dermal matrix from the box, which is more easier, and we take as much as we want to. If we already have the graft, we have to try it to the tooth. After drying and cleaning the tooth surface, we can lay endogain on it. We have to place tension-free sutures and have a tension-free flap. With this technique, we can change the gingival biotype. Before the surgery, we changed the shape of the tooth. And so, we wait for long-term stable results. So we can say that there are quantitative and there are changes in the theoretical views. So from a quantitative view, we got to a qualitative view nowadays. We are using small grafts, connective tissue grafts or acellular dermal matrices to have an aesthetic outcome, and we can think about that we have still regeneration in the end. With that aim to have regeneration, we choose regenerative materials like enamel matrix proteins. The most important thing is the flap. We have to use pedicle soft tissue grafts. The blood supply is really good for these grafts, and we can choose from different type of pedicle flaps, like coronary advanced flaps or rotational flaps. The combination of the graft and the flap gives a stable, long-term result. But in thick gingival biotype, the literature tells us that we can have good long-term results even with pedicle soft tissue grafts only if we have enough keratinized tissue apically from the lesion. So from the quantitative aspects we get to the qualitative aspects from the beginning of the 90s. So this lecture wanted to give a survey of etiology and therapeutic aspects in root coverage surgery, and I hope so you got it. So thank you for watching, thank you for the botiss team to the possibility to be here now with you. Thank you. So I'm looking for questions now. So occlusion, there is a question about occlusion. Of course, occlusion is very important. In this lecture, we were not talking about the defect examination, but if you think about the defect examination, we start with the position of the tooth. We have to check if there is a rotation, is there an angulation, And of course, we have to check for elongation or bad occlusion. And if it's like that, we have to change it. If we want to cover the recession, but the tooth is still in a bad position, we will have a recurrent recession, or we will have we can't cover the recession. There's a question about root surface treatment. The literature says that it's enough to clean the surface of the root. So usually I clean it with Grafts and don't use any acids or something like that. But of course, regenerative materials like Emdogain can help us to improve our outcomes. So I do only two things. I clean the surface before surgery, the surface of the recession, and when I made already the flap, I place Emdogain on it. Some people say thank you. I thank you to watch us. But so there is a question about tissue harvesting methods. I was using the trapdoor technique before. Nowadays I'm using the technique from Professor Zucchelli, which is a small epithelialized tissue graft, a thin one, and then I deepithelize it. So I will have a so-called true connective tissue graft, and that's not too big. That's a good quality tissue. I'm using this one, or I'm using Mucoderm, which is a very good alternative in several cases. There is a question about the lower incisors. The answer is yes, I have treated the lower incisors too. In this topic, in this lecture, I was not talking about this, but there is another lecture where I'm talking about. There are a lot of special aspects, so it's not an easy. It's not easy to treat these. I don't use hyaluron acid products, so I cannot tell anything about them. This is a good question. What kind of graft is the best for the aesthetical region? In my praxis, I'm using connective tissue grafts and Mucoderm. And if you have a Miller 1 or Miller 2 class recession, then Mucoderm works good. So if you have to treat the whole arch, maybe 10 or 12 teeth in one session, then it's easier to use Mucoderm. You have so much, as much you want to have. But with the autologous tissue, it's not that easy. You have to harvest it, and maybe you cannot harvest as much you want. Of course, the autologous tissue, the connective tissue, is the gold standard still, so my answer is the CTG, but in several cases the Mucoderm is a good alternative. Dear Tamás, of course, there is an indication for FGG. For example, you have very nice cases around periimplant sites. And yes, if we want to have a bigger gain in keratinized tissue, then it's better to use FGG. So there is a question about the acellular dermal matrix and mucoderm. So this is the same thing. Mucoderm is a acellular dermal matrix scanner graft, and usually I'm using it with a tunneling technique, but it can be used with other envelope techniques or coronally advanced technique with vertical incisions too. So there is a question, if I understand it well, is it about where to place the graft? And if it's a connective tissue graft, you have to place it apical to the cementoenamel junction, because it doesn't want to cover the recession, but to stabilize your flap. So the flap should be a bit coronal to your graft. And the sutures, I usually use sling sutures. There is a question about mucoderm and vestibuloplasty. I'm not sure about it because I didn't try it for vestibuloplasty. I can tell you for sure that you will have shrinkage of mucoderm, almost the half of the graft. But I left it uncovered in some cases and it works well. But you have to think about the shrinkage. So there is another question about acellular dermal matrix, and my answer would be that there is alloderm, which is a allograft, and there is mucoderm, which is a xenograft. But both are acellular dermal matrices. Of course, they are different. So if there are no other questions, then thank you to be here with me.
Thank you very much, Dr. Hangyási, for sharing your lecture and your insightful information with us. We'd also like to thank Botiss for making this online course possible. And thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You'll receive an email notification with a link to the recording. Further questions for Dr. Hangyási may be submitted directly on the website, on the courses page, under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Hangyási will be sure to get back to you as soon as possible. Please be sure to visit the Botiss educational platform, www.botissacademy.com, and keep an eye out for a growing schedule of online courses. Thank you again to all, take care, and goodbye.